Besides that, you feel pretty good?
Brown ones.
Yeah.
They're all at the
The
nurse's.
nurse
you?
is saying she died? Man, what's up with that?
Okay, I got a question. I was watching how to release trigger points in the upper tracks.
Say this again?
I was watching a YouTube video on how to release trigger points in the upper tracks.
Okay.
And so this guy he just kind of takes it, grabs it, and lifts it up, and he's got this needle. But it's almost like an IV needle. It's like, once you get the needle in, you pull it out and it moves around.
Yeah, dry needling.
Yeah, so he's sitting there and he's doing that, and you can see it jumping, like, you can see the muscle twitching. And he's moving it around,
I
moving around.
twitched too if
the neck.
somebody was jabbing me with a needle. I mean,
Oh, but so he finally did it so much that it had released, and he said that's how you knew that it had released, because it would quit.
I don't-
doing all his fast
I don't know a lot about dry needling.
It looked awesome.
You don't suggest it?
It looked.
No, I
wouldn't suggest it at
Not to have it done, but maybe to do it.
Dominique.
So,
Amy.
yeah, you hear, she'd like to torture, but not be
That looks
tortured.
awesome.
I was just gonna know if I could try it on Josh.
Was it released, or did he just like sever all of the muscle fibers that were?
Amy is thinking that'd be cool with a shank.
You absolutely have permission to do it, Josh.
Yeah.
Negative.
Oh, yeah, man, you'd feel a lot better.
Nope. Amy's not allowed near me with any blunt objects.
Or anything plugged into electrical circuit.
Or electrical. Ice pack, hot pack, you're alright.
Every time we start talking about that, I think I just have a burning
You've
sensation
got like
of my inner
phantom
thigh.
pains.
Yes,
To the right.
They're talking about it,
Yeah.
he's like,
yeah, from the right inner thigh all the way to the anus.
it burns. Rectus.
Rectus.
Not the femoris.
No.
Yeah, well, it was actually supposed to be a classroom. That, and I was gonna take this classroom and do all the work for the third and but something changed somewhere. I don't.
Is that still the long range deal?
Didn't know which I was doing the classroom.
Hey, Amy, do mine too. You do mine too.
Hey, yeah. Did you try to look up on the YouTube?
Could you hear it? I wanted to look it up, but somebody took the papers.
Well, she sent me a picture of it.
Why didn't she send me?
Because I asked for it.
Well, because I just showed you to look at it, next thing you know, you stuck it in your pocket. How to get on YouTube for
You
that.
see how top in the YouTube channel right there.
Did you have to log into your YouTube or
He just
no?
wanted
Well, I'm
to
logged
see
in
it,
on
try
my-
it. He
on
didn't
my
even know.
Are you?
It wasn't,
I don't
it
remember
wasn't
not
like,
logging
it
in.
was just like his
class
classroom day.
Oh.
It wasn't like his lectures or nothing.
Look.
That's why I can subscribe to it.
Come back with some meat. I bet you said that they see.
Yeah, graduation coming.
About 45.
Yeah.
But here's the deal, it's 76 yards they can hear, and they, a lot of times they get out of the way. And that arrow whistles going through the air, and a deer at 76 yards, they're gonna jump, not time that means they're gonna be, they're that quick. That's why I'm 45.
I guess I do learn that sound now.
It whistles.
But there's,
Yeah. It would be cool just to see them. I mean, it would still be.
But at that price. But yeah, 6 guys camping, hunting, probably a good time.
All right, this week we're going to begin range of motion, and
I'm teasing.
we are going to specifically talk about how we improve range of motion, and then what things are comorbidities that exist that complicate range of motion. And so our examination this next week will cover four main things. Passive range of motion, active range of motion, active assisted range of motion, and stretching. And those four things that I'm going to talk about are all to improve range of motion. Got it? So we're gonna talk a little range of motion today, a little stretching on Wednesday and on Monday, and we're going to experience several different types. But the thing that I want you guys to walk away with is these things increase range of motion. So when you see this goal, and remember we talked about this last week, we said you're gonna have goals, your PT's gonna write goals, and one of those goals is gonna be increased range of motion, right? So when you see increased range of motion, you're gonna apply one of these four techniques. Now, the other thing is, what's one of the best things to do to avoid having a range of motion issue?
Regularly.
Just stretch,
Just move around.
just moving, just continually moving. It's when people stop moving that they really start to complicate their bodies. And this is something that, this is not a textbook test thing. This is something that I hope to pass on to you, that you begin to use as something in your lifestyle, and maybe you infect your culture that you're around with the way things that you do. You're all going to be therapists, and what's the first word on your title? Physical. And so your job, your occupation, the thing that you're going to school to do is going to require you to have a certain level of health to be able to do your job. Imagine if you can't do some things because you have a low back pain or tightness, and Tara thinks I'm looking right at her and talking to her because she was like, I told her no. But imagine if you can't do that. Does that complicate your ability to earn a living? It does. And so the first thing that I have to do is not convince you to use these techniques on your patients, but in fact to use them actively upon yourselves. You know? And so one of the things that I try to do is say, hey, look, if you're going to stay in this line of work, and after the commitment that you guys have given with money and time, I would imagine that that's something that you want to do, then you know, apply some of these principles to yourself first. All right. So, range of motion is a basic technique used for the examination of movement and for initiating movement into a program of therapeutic interventions. Now, let me go through that one more time. There's two things that you need to catch out of Kisner, and when I say Kisner, I'm talking about the author of this text. Okay, Kisner, this is a fantastic book, and I really urge you guys to keep this book when you're studying for your licensure, because a lot of things will come out of this. So, Kisner gives us this definition, and it's very clear to us that two things come out of it. Used for, first of all, the examination of movement. Now, how do I examine movement through range of motion? What am I talking about right there?
Just the observation.
What am I observing, Paul?
Full range or?
Well, you're looking for full range, but you're also looking to see their comfort level in that range, I would think.
Yeah, what do they do to indicate that comfort's not really
Their
quite?
facial expression.
Yeah, they're gonna give you some apprehension out of their face. And so, a lot of times, I'll encourage you as we're looking at range of motion, not to necessarily look at what that arm or that leg is doing, but kind of look at their face. Because that tells a big story, doesn't it? It tells us maybe just how intense this is. In fact, I was stretching a little girl the other day in the clinic over in athletics, and I take her up into stretch, and I tell my students who are there, I say, now I want you guys to watch her face, and they were just like, you didn't have to tell us to do that, because that's where we were looking. And I was like, good job. Because man, the second I bring that leg up, she's just like gets, and then she arches her back, you know, because that's going to help and all these things. But we can see visually by our inspection a lot about their apprehension. What else am I looking for? What is the examination telling me? How do I do my examination of range of motion? Hmm. What's something that's really important for me to include when I examine Miranda's left shoulder?
That is our shoulder. Cause that's
Go,
important.
man.
You're right. Hey, listen, do you know how many horror stories? Like, I had a student go watch surgery one time, and she came back and she said, yeah, he shoved the scope in the wrong knee. That's no bueno. So it is good, isn't it? Mr. Riverton,
It's coffee, it's good.
we have coffee. Would you like some?
I've had some.
That's our recruiter. Good guy.
Their prior level of function?
Their prior level of function. What is it, though, that's gonna tell us what their probable prior level of function is?
Non-affected side.
What's that?
They're not affected.
Non-affected side.
Yeah, the contralateral side, the non-affected side, the uninvolved limb. How many ways can you say it? I mean, what does Jerry like for you to call it? Unaffected? The good one? Let's call it the good one. You look at the good side, and if the good side has full, then you're like, okay, now I know what I can look at. Bill has said this for a long time. He said God gave us two sides so that we could examine both, right? And it's really important. Thursday night, I go to Poto High School football, and kid hurts his knee, and I get him in there in the locker room, and I go, I think, oh my goodness, that ACL is torn. But I always go to that good side, and when I go, and he's feeling that ACL pop and tether, and he's like, what's that? And I'm like, that's your ACL, that's good. But you notice how it doesn't do that in this side? And he's like, and here come the tears. Like, he doesn't even have to acknowledge what he just did. I mean, he just, boom. And so, it's important for us to always look at the good side. Because a lot of times, you as therapists, and me, I'm the first person who needs to be in this list. We tunnel vision, don't we? And we say, okay, this is what's wrong. And we immediately know what's wrong and how to fix it. But we also need to know what's normal for this person. Because sometimes normal is not that great. Anyways, I mean, Blake's elbow flexion is not super. Is it? No. But would you trade those bulging biceps for more range of motion? Heck no, he says. Okay.
Well, I had a friend of mine in high school, he can only turn his hand like this far. So, so if you go up there and go, oh my God, something's wrong, but you look over here, you can tell, he just couldn't turn his hands flat. He had to turn his hands flat, he had to turn his whole body like that.
Yeah, and do you ever see people do this? Hang on, I've got this one. I can do 90 degrees. You want me to do 90 degrees on my left side? I got that. I got 90 degrees, hang on. Do I have 90 degrees? No, I don't. You know what they'll do though? Patients are conniving. They think of ways on how they can convince you that everything is okay. I remember when I had braces, that I walked into the orthodontist, I wanted those things gone. And I walked into the orthodontist and I practiced for 3 weeks on aligning my jaw so that my mid-bite was perfect. And I walked in there and I held it. And he was like, this is amazing, I did great work. And I was like, take it off, take it off. But what do? When you want gone, you are ready for healthcare to go away, you want to resume your life. Are you willing to do this? Aren't you? And so aren't your patients willing to do that? I mean, let's go back into this. We haven't went back. Let's go forward into empathy and knowing what our patients are going through. They don't want to be there. Okay, they don't want this. They want to go home and resume lifestyles, so they're willing to throw that arm up. Now, the second definition that Kisner really wants us to understand is this is important for the initiating. You've got something for me, huh?
Just listen.
You just hanging out?
Rent a wetsuit today.
Rent one? Just buy it.
No, buy it.
Buy it.
I'm not gonna buy it.
Buy it.
I'm not gonna buy it.
How much you gonna pay to rent one?
$80.
You can buy one for $100.
That's $20 I can say.
And then you just gotta rent another one,
Huh?
then you'll have to rent another one.
I'll never use it again.
Oh, fair enough. Hey,
Hey,
Aaron,
yes,
didn't I tell you to do that months ago?
what?
Rent a wetsuit, get a wetsuit.
Well, if I rented one for that
But
long,
it took
it cost me
Becky,
a lot.
there comes Becky, and Becky swims at one time, but old Kendall's, his opinion didn't matter.
That's not what I said.
Becky like swung your.
No, it's not Becky, it's my wife.
Oh, that's important, you better listen to her. Number 2 definition, examination of movement and for initiating movement. Is range of motion important for initiating movement? How?
If you got no range of motion, you can't get no initiation or nothing out of it. You know what I mean? You can't move, then initiate movement don't mean nothing.
Well, let me read the rest of the statement. Initiating movement for a therapeutic program. What are you gonna do as therapists? You're gonna return them to as much of their prior level of function as possible, right? Yeah? Okay, so what are we gonna use first? What are we gonna use first? Have you thought about how you're designating and designing and constructing the therapeutic program yet? One of the most important things that we're gonna try to get you guys to do is to go from scratch. You just got handed a patient, now start. What's the first thing you can do? One of the first things is always gonna be passive range of motion. And what does that tell you? It tells you a lot, because the second I put this patient and I start moving that patient, I understand a lot just by saying, okay, that's what they have. There's clearly a range limiting something that's keeping them from going into full elbow flexion, right? So clearly, I can use this one technique, passive range of motion, to assess, but then also to initiate the therapeutic program. It's important for us to know what our first steps are. Some patients don't require that, do they? Some patients say, I have full range of motion. I need to strengthen this. I need to do something different. I don't need to worry about range of motion, but one of the most important things is starting a therapeutic program with range of motion and centering everything off of that. So when moving a segment through its range of motion, all structures in the region are affected. How are muscles affected when moving a segment through a range of motion? What happens to a muscle?
Shorten or lengthen.
Let's use that. They shorten or they lengthen, don't they? Let me go back to this. If I'm going to use the elbow and flexion's a problem, what muscle has to shorten? And what muscle has to lengthen? And so what is the bicep? It's an agonist. And what's the tricep? It's an antagonist. Okay, so that is clear to us. Now what about joints? What do joints do? How are they affected?
It'll get the synovial fluid moving in there.
It's going to get synovial fluid. And how important is synovial fluid?
Lubricates and nutrition.
It's big. I looked at my wife's car and the sticker up yesterday, and I'm sitting there waiting on her, and it's 5,000 miles over an oil change, and I just melted down in the car. I'm talking like somebody just dropped a nuclear bomb in there, and I just melted. I was like, oh gosh, really? 5,000 miles? It's huge to have that synovial component in the joints. And if we have that, what does that do? That helps that joint move. What about capsules? What do capsules have to do with a joint? What is a
What
capsule?
holds in the synovial fluid.
Do what? Yes, but what's the capsule? Can someone describe what, I mean, like, what the capsule is? Not necessarily that part, but what is a capsule?
Helps hold the joint together.
It is kind of a ligamentous tissue that helps hold the joint. It encapsulates the joint, doesn't it? And so, if we didn't move something for a very long time, what do you think would happen to that capsule? It's going to start to restrict and tighten up. And so, if that happens, are we not going to have to apply some kind of technique to loosen it? Okay, so capsules. Ligaments. Ligaments are a little different here. Ligaments are non-contractile, which means that they don't really shorten, and if they lengthen, that's not a good thing, because they lengthen because something stretched them. And now that we're kind of talking about this, what is it when a ligament is stretched? Oh, Hush was about to get the wrath of. It is a sprain with a P. And now therapists, you are only going to be as valid as your grammar allows you to be. If you tell a doctor,
How about you got like 5 seconds?
go
Or what
about
time?
10, 15.
10, 15?
Yeah.
Okay.
If you tell your doctor that you strained your ankle, it's not a big deal. But if you're a PTA and you tell a doctor that you strained your ankle, especially an orthopedic doctor, and guess how many orthopedic doctors you're going to work around? They're going to go. Guess who then is going to look bad? Me. Cue me, because I was supposed to teach you about these things, right? No more interruptions. So, what did you do to your ankle when you hurt those ligaments?
Sprain.
Did you spring it or sprung it? I'm trying to get finger foods out of this deal. Did you spring it or sprung it? No, you did not spring it or sprung it. You got a sprain and you had an ED. What did you do if you hurt your muscle by stretching it? You strained it. It's important that you don't mix these words up.
Did you strung it?
There was a.
You strung it? I strung my hamstring.
Commercial, and they said that they treat muscle strains and sprains.
Of course they do. Of course they do. They're talking down to the least of these. Okay,
So
what about?
What's your segment on the ligaments, though? What was? I mean,
Well-
you came up with something on the ligaments, sprain and don't strain, is that what you want?
I want you to know that ligaments need movement too. I don't really need you to write anything down on any of these.
For your test, I want to know everything.
Well, I'm glad you did. Hey, let's talk about this fascia stuff. Wait a minute, she says.
They need movement, but they're non-contractile. Never mind, I got this, never mind.
Movement within its normal limits.
Yeah, I got this.
There you go. Don't get hung up on the little stuff. Fascia. What is fascia? It's like,
Connective tissue.
I got a bone, and I'm gonna slap some muscle around it, and it's gonna move joints. And then I'm gonna take saran wrap and I'm gonna wrap that whole thing so it binds that muscle up. Does that make sense? And it's a big one piece too. I'm not like taking multiple layers. I've got one big piece of binding. And so, just real quick, how many, show me some hands, if you have ever participated in the butchering of an animal. I got a couple rednecks in here with me, that's right. And so, what I find is really cool, and I need to video this, I really do, because it's important that you conceptualize this. You have an injury, and when you have an injury, according to the acute inflammatory process, what happens?
It tears.
Well, well,
Starts when it stretches.
not inflammation, but let's call it specifically swelling. All right, so when swelling happens, it hurts, doesn't it? I mean, we respond to that, we say it throbs, it throbs, it throbs. Okay, well, let's go with this. As I lay that deer quarter out, like the ham right here on this table, I always rinse it with a hose. And inevitably, I will have nicked a piece of fascia. The fascia is still binding that meat, okay? Unless I take it off. And I don't. I leave it on there for a little protection. And I'll have nicked that. And as I'm washing that muscle with a hose, I'll be using a little bit of pressure behind it. And eventually I'll get some water. And that water will land between the fascia and the muscle, and it will start to expand like a water balloon. And I'm talking, I can shove that dude into that nick, and it'll just go, Now, take for just a minute what injury does. Injury does the same thing, shoving blood in between the muscle and the fascia. Now, do you start to understand why pain occurs?
There's pressure.
And why swelling is bad, not bad, but painful? It's because of pressure. And what does that land on? Nerves. And what do nerves tell you about pain? A lot, right? So is fascia an important part of this talk? Yes. And when I come in and I talk about kinesiotape and procedures too, in a few weeks, I'm going to give you a whole kinesiotape lesson. I'm gonna ask you to remember that deer leg and how I shove that water hose and it expands it out. So I've got fascia, and fascia is pretty tight, wouldn't you say? I mean, if you look at your leg, you'd say, well, I don't think I have any extra fascia flopping. Okay, so I've got this fascia binding my muscles, and if I have an injury, it's going to pull on this fascia locally, like right here, okay? Because I pulled my hamstring and I have fascia that's pulling here because of the injury. Wouldn't you hypothesize that if that fascia got tight here, it would also be tight down in here, wouldn't it? Because fascia, remember, it's a one big binding around it. And so if fascia is tight here, you're going to have some fascial tightness down here.
Is fascia like over each individual muscle, or does it like cover your whole inside? Like one big,
I don't really know if there's a conclusion of one fascia to the next.
like, does it cover fat?
Yeah, it's binding the whole
So it
thing.
kind of holds everything in.
I mean, you have fat you have several different types of fat though. You have intramuscular fat, and so yes, it's going to cover that. And then you have fat outside of the muscle. Does it cover that fat? I would say that there's certainly a binding there. There's a word that they use, the aponeurosis.
Probably keeps it from being all
That-
lumpy,
Oh, yeah.
or to a point. I mean, I'm a little overboard on it, but, you know, it probably keeps it all wrapped in there tight.
Well, I don't know, to go to your original, I don't know if there's ever a part where it seams, you know? I've not had a gross anatomy class to look at that, but I have had gross anatomy in my shop with a deer, and believe me, I spent some time looking at it, and it seems like there is some, like, the best way I could say it would be seams, where it ends here and it starts over here.
Because I've seen steaks, you know, that have some, you know what I mean, it's kind of on one side of it or something.
Mhm.
So, I think it might be individual.
Is that really the fascia, or is it like just?
The sinew, you wanna call it the sinew, don't you? You're like, right, you wouldn't. That is, two different types of tissue. But I don't know that I can really give you a good breakdown of what the difference is. So, what I want you to understand though is if fascia is getting pushed up here, it's gonna have some, almost, does the term radicular pain mean anything to you yet? Not the same thing, but it's going to have a referred pain or tightness.
Radiating pain?
Not really, because if you start saying radicular or radiating, you're clearly talking about the last thing on this list, and that's nerves.
Well, like a deep thigh contusion, like a football player gets a hip corner or something, is that the blood between the fascia and the muscle?
Yes,
Okay.
yeah. Do you ever massage that? No, because you're just basically picking the scab off the bruise and letting more bleeding come in. There's a really good picture if you can see kind of how someone you'll ask them, where do you hurt? Where's your pain? Especially in my job as an athletic trainer, I can see a muscle injury and I'll say, where does it hurt? And they'll say, it hurts right here. And you see what I'm doing? I'm covering a big old service area right there, a lot of real estate. I'm saying, no, I need to know, can you put a finger on it? And they say, I guess it mostly hurts right here. And that's good because I can identify where I'm dealing with. But they complain about this pain being very diffuse, and a lot of times that's fascia. And so you're going to affect fascia with range of motion and that's kind of the biggest things. How do we affect vessels, arteries, veins with range of motion? How is that?
You get blood flowing through there. but-
Yeah, because if you have, even with the most subtle active range of motion, you're going to initiate some focal blood flow into that area. And then nerves, well, what we found out on Wednesday was that nerves sometimes come into this when some of you were getting your hamstring stretched. And I said, now think about it. Where do you feel that? Do you feel that in your hamstring, or do you feel it in your back of your knee? And some of you are like, this is in the back of my knee. Okay, that is clearly neural tension. And that means the nerves are tight. Because nerves tend to do the same things that muscles do. If we spend a whole lot of time sitting in these wheelchairs, or even what we do too much of, and that's sitting, if we sit a lot, the nerves, the muscles, the vessels, the ligaments, capsules, the joints, and the muscles all do one thing, and that's they adaptively shorten. It's not necessary for them to move, and so they start to get tight. And so when you see people with this issue right here, you see people standing like this, and as they get older, what does it do? Does it get better? No. It tends to get worse. And pretty soon they're like, man, I got all these knots in my shoulders. And you're like, I can see that. Why? Because I've let my pec minor get super tight, haven't I? And so what is my upper traps, my rhomboids, what are they all dealing with right here? They're just like, and so they have to lengthen, and then they get all these big knots in them, and they're trigger pointed, and all these things are going on, and now you get to deal with just the lack of their responsibility of staying in a more appropriate posture. So range of motion is measured with a what?
Would you need to have them do some kind of stretching, or?
We're gonna
My
talk.
wife's grandma's got that problem going right now with her shoulder.
We're gonna hit it here very soon, this week.
Good.
Range of motion is measured with a goniometer. And when we look at range of motion, do we look at the goniometer and say, okay, I just want to measure how far I can move it as a therapist? What's that called? Passive. Do I just want to measure passive? No. In fact, what should I probably do first? I should probably look at active and just at least have them do active, shouldn't I? That way I understand what their limitations are. Because a lot of times that tells me how far I can take them passively. I always want to measure actively first. And I always want to look at active range of motion.
Well, we learned about the goblet tendons and stuff. Should we let them try a few times or whatever before we do it?
That's a fantastic, and what I would tell you is clinically, yes. Textbook, I don't think you're gonna have to worry about that. Now, not in my class, but there may be a time where you would see a question. One of the things that I'll even encourage is that people let their patients walk and move and get, for the lack of a better word, limbered up before we start evaluating range of motion. One of the first things we do at the track is we do a simple walk. One lap around, easy walk. And that's just gonna get the blood flowing. And then we're gonna do our dynamic stretching. And then we're gonna do our big walk. But the thing is you gotta let you guys notice that as you stretch things, and then you let those Golgi tendon organs kind of work in, you will get a better range of motion. And that's gonna make you as a therapist look better because you're gonna get greater measurements, and you're gonna be able to present to your PT and to your doctor and the insurance that you did something better than, even if it's just 2 degrees, that's substantial. What is active insufficiency? That should have already hit your plate in kinesiology by now.
Where you contract over both. For the stretching over 2 joints,
Not stretching, it's the contraction, active contraction.
you can't fully contract over the 2 joints.
So I've got contract, and when it contracts, it reaches a point where it's as short as it's gonna get, isn't it? Like the bicep, it's just as short as it's gonna get. But can I not go in there and passively add a little range of motion to that? Okay, so active insufficiency. Now what about passive insufficiency? Bill said something about this in the lab the other day. Was it the other day or the?
That would be with the assist of a PTA or PT though. the
Yeah.
passive.
It's passive. External force is being applied. What's passive insufficiency though?
The link.
Where it can't stretch over to.
It elongates at its maximum elongation, but there's, see that?
But isn't that only in the
That's the
two
passive.
joint muscles?
Yes, yes it is. But it's important that we think about it because how many two joint muscles are we actually stretching or applying range of motion to? A lot, a whole lot. The one that I think about the most is the calf muscle. The calf muscle starts above the knee, doesn't it? At the femoral condyles, and when it comes down and inserts in the calcaneus, that's when it becomes a two joint muscle. And you were stretching that hamstring up, and what did that foot want to do? You want to do this, and what happened when you guys took those toes and went? They were like, "Oh, you're gonna have to back off a little bit." Yeah, and so it's important to think about how are we engaging those two joint muscles. Factors leading to a decreased range of motion. There's a lot of them here, and I want to kind of hit each one of them, but a systemic joint, neurological, or muscular disease. Well, what's a systemic joint or neurological or muscular disease? Let's go back to David's class. ALS. He's just thinking ice bucket challenge, man. He was like, come on.
Muscle dystrophy.
What else?
Parkinson's.
Parkinson's. Oh, man. You ever heard of, do you remember cogwheel? What's that? Rigidity. Have you ever seen it? Man, like, I'll never forget the Parkinson's patient I had in my clinical. I can't say his name now. He was, when I say Indian, I don't mean Native American. I mean, like, he was from India. And it's really unique to work with a patient from a different culture. And I'll bring this guy up several times, so I just don't even remember his name. I couldn't say it very well then, but I remember how rigid he was. And he had a hip replacement, Parkinson's, dementia. We listed some comorbidities. This is like legit. This was the patient to have for a student, man. I mean, they were like, yeah, we're giving this guy to a student. And I remember so clearly that cogwheel rigidity and how hard it was to do range of motion stuff. And we had to. He had a hip replacement. How important was it for him to be able to do some things? But with Parkinson's and dementia, and the fact that he would not let a female touch him, and there's not a whole lot of males around to help him. Yeah, I'm breaking down some barriers for you guys today. We're getting into some big, deep stuff. We're bringing neuro, disease. What's that class I teach in the spring? Psychosocial aspects in, some therapeutic exercise, and we're bringing it all in and saying,
Somebody was making that noise.
Tom E.T. is calling. Anyone want to answer Tom E.T.? Tom E.T.? Anyone?
The extraterrestrial thing.
Oh, that's me. Sorry.
No problem. So,
Should've put it on there.
when we think about this one patient, they have systemic issues that I cannot deal with without having some help. And then I got Kathy saying, well, I felt Kindle, and he's like, okay. You know why?
Because women are like totally, this is not me saying it.
It's a religious. It's a
Wait,
religious-
everybody's got the recorders on, you got Jim ready?
They feel women are inferior to them in
Yes,
their country.
It's a religious thing, right?
it is, yeah.
Which is wrong by all means. I got 3 daughters, I'm totally against that.
I like that cover. And so, when we get into psychosocial aspects, we'll talk a lot about culture. And I love that, that's a great section. What about this? What about trauma? What does trauma do to our range of motion?
Makes you afraid that.
Muscle
What was that
wasn't
hard or?
Yeah.
Yeah, yeah, good, take.
Hang on, that's a lot of people do the toe touch. And then I got these external hill people. Stance faces short, okay? And I had a girl who strained her calf, and I'm trying to do an exam on the calf. She's like, oh, don't touch it, oh, don't touch it, oh, don't touch it. And I'm like, ring, ring. How else can I examine if I can't, don't touch it, don't touch it. They don't want you to touch it. Okay, fine. Here's some ice. But we get very sensitive after trauma, don't we? We don't want people to touch it because it hurts, and we don't want people to make it hurt more. And as therapists, you're going to have to put your hands on those very delicate tissues. What about surgery? What does surgery do to us? Same thing. You know, we don't want people to touch that surgery. Now, on the other hand, do we not have something that we put on people after surgery? What's it called? CPM. Yeah, I saw a deal. I'm watching a little football yesterday, and there's this thing. What's it called? The Cairo something or other. Anyways, you lay down on it, and it's this thing, and it's this little continuous passive motion for the lower spine. And I was like, gosh, man, when am I going to think about something stupid like that and making some money? It just takes one, Tuck. One thing, and you're set. How about inactivity or deconditioning? What does that do to our range of motion? What does a person look like if they've been in bed for a month? Well, they're not this. They're this. And then when you get them up out of bed, it's almost like they don't even move. They can, like, you return them to weight bearing, you know? Sometimes you have to use this tilt table, don't you? Because they're so disoriented to being upright. And so it's a big deal. And how fast does this happen? It takes like just a few days before these things start to really get bad. I mean,
Well, we learned 24 hours from
Yeah.
muscle, but what about like your joints and stuff
well,
like that?
here in a minute we're gonna get into this.
Okay.
I'll give you a graph in your book. It's a great graph, or it's a table. Jed came in though last week, remember, and you were doing his ultrasound. Huh?
She was just talking to me about it.
On the side. Hey, it helped him. You know what he did the next day? He showed up on Thursday. You did it on Wednesday, right?
Yes.
On Thursday, he gets out of his truck and he says, "Hey, watch this." That was big. Like, that was huge for me to see that. He's like,
Yeah.
"Feel good." And
Now you're
so,
more of a believer in ultrasound?
She even had it plugged in and everything.
when it's used appropriately, and in that case it was, but you know what you do in the clinic? What are your clinical instructors gonna do? They're gonna be like, just put it at like 1.5. There's no validity to what they're doing. They don't even know. Are they heating the temperature? Don't give me started on that. What about bed rest? Does bed rest affect it? Absolutely. How about immobilization?
Yeah.
All these things are gonna be things that you're gonna deal with. As a therapist, you're gonna have to say, okay, I need to improve this range of motion. And you're gonna have to be able to use strategies that are data-driven strategies, not just, I'm gonna set the ultrasound at 1.5. That's not data-driven. I need to know, and this is why those cards are so important. Because, A, Kendall doesn't remember what it takes to get a 2 to 3 degree increase. You know what I did when I'm over there? I was like, I don't have a book. So I left, came over here, looked it up, and went back, because I didn't know what the parameters were. I can't keep it in my head. Now, if it's documented in a note, and you do it day in and day out, you can probably remember like that for that patient. But for 2 to 3 degree increase, which is what I was after on his adductors, I didn't remember. But it has to be data driven, doesn't it? What's that?
Well, yeah, and also, I did another ultrasound on a lady that had gamekeeper son.
Uh-huh.
And, Bill was asking me for how long would I do it, and I just said 5, and he said, actually, that's just what they say in the clinic to be able to charge, but
That's it.
said that he's read a lot of research, and so he, only had me do 3.
Yeah.
He said it was just as beneficial.
7 is actually what Medicare requires.
Really?
Yeah. If you do what? 8?
8 minutes, yeah.
It's went up.
It's 8 minutes.
You gotta do 8 minutes. So here's what I'm gonna do. I'm gonna set my ultrasound to do what I want it to do. And and when the buzzer goes off and they're like, is it finished? And I'm like, nope. For 5 minutes, I'm gonna sit here like this,
But that's from when you start.
doing nothing.
That's from the beginning though, when you start and get patients settled, and you put them in the position you want, then you turn on the
I don't know, I
machine.
think that's from the time you get started.
I
It
thought
has
it
to
was
be
the
an 8
whole,
minutes.
the whole shebang. Is it really?
I think you have to, it's the time on the clock, so. Doesn't matter if it's plugged in or not. All right, so let's talk about this, types of range of motion.
That's what I.
We have passive, active, and active assist, okay? So let's look on, I'm not familiar with that, hang on.
51?
51 sounds good. 44 is in the purple book. Does anybody else have the purple book? 2, 3? Is this your book? This is not your book. Okay, so on page 44, it talks about these. Passive range of motion is a movement of a segment with unrestricted range of motion that is produced entirely by an external force. Now, I want you to pay attention to that definition.
52.
This is another huge thing. You have to understand that Kisner wrote these things this way for a reason. She said, let's just turn it this way so we can both read. A movement of a segment within the unrestricted range of motion. You have to use this term and apply it. If it restricts, then that's not their range of motion. The second you start to feel something restricted, that's it. This is the range of motion right here. And it may be, okay? And it's important for us to know how to document that too. We'll get into that later. But this is unrestricted range of motion. Passive range of motion is in the unrestricted range of motion.
Do you see a lot of issues within clinics, different PTAs taking passive range of motion and one person is going and stretching and the other, one
Yeah.
person's doing it right and one person is stretching and.
Yeah,
getting
because
stretched.
they will refer to it really pretty poorly, and they'll say, would you stretch that patient? Well, there's a couple things that need to be addressed here. First of all, stretching is a skill technique. And I know some of you are like, well, how is this a skill technique? But this is a skill technique. Active range of motion is not a skill technique. In all. It is, but I can let an aide do active range, or passive, I'm sorry, I should have said passive. I can let an aide do passive range of motion, but I can't let an aide do stretching because of some boundaries there. And so, yes, I think certain therapists are really missing the boat a lot of times. They don't grab the concept of what you're telling them to do. Is it active range of motion, or is it passive range of motion, or is it stretching? Because there are clear rules that we have to abide by. And if you stretch that tissue too early, you could injure them more, or you could complicate the patient. And so you don't always do it that way. When passive range of motion is what is desired by your PT, and they write the goals for that, that's what you do. Even if you're like, man, I got a PT who doesn't know what they're talking about, this patient needs to be stretched. Well, you're still under that scope, and that's what you have to do.
It seems like that would cause all sorts of issues though, if you've got people doing it differently. One day in a note that says, oh, they got 30 degrees, next day they get 60, next day they get 30 again, next day it's 65.
And it goes back to, what is the goal? And for some, that's not a big deal, but for some, that's a huge deal, especially if the doctor said, I told you I did not want this patient doing, I had a girl a few years ago, well, you remember, you know, Jen, she was a rotator cuff repair, and they also tightened her shoulder up. The glenoid labrum was torn, and so they did a rotator cuff and a labral repair. And Dr. Smith said, I don't want anything other than passive range like this. And he like said 45, and he gave me all these parameters for 6 weeks. He said, I want that to scar down really hard. So, okay. And so for 6 weeks, there you go. That's it. And that was passive range. 6 weeks. That's all we did. And on the next rotator cuff, he'd be like, okay, I repaired a rotator cuff, do some passive range for a week, and then I want you to start stretching that. Because if you don't stretch it soon enough, you get this condition where the muscles scar over really hard, and what's it called?
Contracture.
Well,
Adhesive capsulitis.
frozen shoulder, adhesive capsulitis, and then they're going into the doctor and they're like, I've been going to therapy, but I go into this. And he's like, you better get that moving, or I'm gonna go back in there and move it for you.
So
And
did
they're
she
like,
have trouble after only doing 6 weeks of, or after doing that? for so
Well,
long?
she had a restricted shoulder. Yeah, I mean, like, here, I mean, that was it. And so she really was successful as far as he was concerned, but she was like, how am I supposed to play this sport or do this? I'm like, well, that's kind of the goal, was to restrict you down. And by the way, we're gonna put a big old shoulder brace on you. That was a whole different story. Active range of motion. Active range of motion is the movement of a segment in the unrestricted range of motion and is produced an active contraction of the muscles crossing that joint. And sometimes we will do things and we'll say, we're gonna do active range of motion. We're gonna start active range of motion. And people are like, great. And it may not have any resistance to it whatsoever. It's just doing what they can, right? So we start them in passive, then we move them to active. And then we'll say, hey, look, it's time for you to do an active range of motion in which an assistance is provided manually or mechanically by an outside force. Because the prime mover muscles need assistance to complete the motion. And so we hang this pulley system up and we say, okay, I want you doing active assisted range of motion. So they're pulling up and they're like, I'm coming. And then it stops because they're weak. And so they take that pulley and they just pull it up a little bit more. Is it stretching? Probably. There's probably going to be some stretching in there. But that's okay. It may be that that muscle's weak too, and that muscle needs just a little help to keep going. We're going to do that soon in lab where we show you. In fact, I had full intentions of doing active assisted last week, and I just didn't get to it. With a wand or there's several different ways of doing it. A towel. One thing that I do with my shoulders is, especially the home health ones, is I teach them to take that bath towel and they drape it right here, and then they grab a hold of it here. And what am I improving? Don't say elbow flexion.
Extension.
Internal rotation.
Internal rotation. One of the most important things that you have to get people back to doing. I mean, there's some men who still carry their wallet in their back pocket, and they want to be able to internally rotate enough to get it.
ADL, washing your back and stuff.
Isn't it important for us to have normal range of motion and internal rotation? But that's a big one. But I just take that towel and I internally rotate, and then I take that towel and stretch it some more. So sometimes stretching and active assisted really gets kind of more of like a self-stretch. And so you have to be careful about how you word it, because you're not going to want to put down that you're stretching where there is acute inflamed tissue, passive motion is beneficial. I'm not gonna say that once, I'm gonna say that again. Where acute tissue damage has occurred, you can do passive range of motion. Now, there are some ifs. I can't cover every if. Bill does that in Ther Ex II. But what you need to understand is that when an injury occurs, you can do passive range of motion. The greatest example that exists is a person has a total knee arthroplasty. What do they have? Knee replacement. They wake up from surgery. They get pushed into a room. And that day, a PT comes in and says, let's do your eval. Okay, here's your CPN. Boom. And they put them on it. The day they just had a brand new knee put in, and they're on this machine that's doing this right here. Passive motion is okay in acute injury. That's just it. There are some things that you can't do because of certain restrictions in motion, but like a good example of this is an ankle sprain. An ankle sprain. What did I do to my ankle? I damaged ligaments. Let's use damage. I don't like torn because people are like, I tore all these ligaments, and you're like, yeah, you have a sprain. I can't take that joint and go into plantar flexion because I'm only going to stretch out damaged ligaments. But I can go into dorsiflexion. Okay? And if you know the pathomechanics, that makes sense. If you don't, then just trust me.
Well, but there's one ligament that does dorsi, right, and on the lateral side and two that does plantar, right?
Ligaments don't form any kind of.
Oh, never mind.
So one of our big indications is acute inflamed tissue. Inflammation after injury or surgery usually lasts 2 to 6 days. When a patient, number 2, this is the next indication, when a patient is not able or not supposed to actively move a segment
Like after a CBA or something?
after CBA. One of the hardest things that I ever watched, I walked into, during my time at Mercy, we walked into the unit, that's what they call it, it's ICU, and ICU is just immediately like a drag. I mean, like, they keep the lights different, the paint's different, the tone is just somber, it's a drag. Like, if you're a dark person, you don't want to spend too much time in the unit. Like, it's not healthy.
Where's your set?
ICU in Mercy. And those people, I don't know what they, I don't know. I just
My
can't,
wife's been ICU nurse over 6 years now.
I just don't know how they do it. I walk
They
into
don't care
ICU.
after a while.
Huh?
They get kinda numb about it after a while.
I'm gonna pray for your wife tonight. So,
That's good.
I go into this room with Shane, my CI, and we roll in there, and this dude's laying in the bed, and Shane told me the story as we walked in there. It was an OD.
That's what
Don't
they're
know what he
getting
OD'd on, but he OD'd, and he's got a central line in his left femur, or his left thigh. So we're just gonna do passive range with the rest of him, and he's good. I walked in there on the first day, and guy's shaved head, got a little bit of scruff on his face. And we walk in there, and I just kind of turn around, and there's Mom sitting in the corner with this look on her face. And I quickly notice her, you know, somebody's here. And so we tell her what we're doing, and we're doing our range. And 5 weeks later, I'm about to leave my clinical, and he's still laying there. Now he's grown out full facial hair, but he's still in the same position. No change. Why would you do it to your body? So, it's not you, it's what you do to the people around you. This was a bad deal, and we're doing passive, which fortunately we had one PTA who was always like, I'll go to the unit, because there were only like 5 patients in the unit, and she'd spend all day there. And I was like, good. do are 30 in the hospital. You do those 5, you stay there, you don't ask me to go with you, and I'm good. I was completely happy with that. We did passive range of motion because that's all we could do. This person was brain dead. And the orders were to do passive range of motion, basically to give joint nutrition, and they weren't moving. Do you have a question, or were you stretching?
Stretching.
Stretching. Here we go.
A little bit he can.
Take a look here for me at goals of passive range of motion. Primary goal is to decrease the complications that would occur with immobilization. Specifically, the goals are to maintain joint connective tissue mobility, minimize the effects of the formation of contractures, maintain mechanical elasticity of muscle, assist circulation and vascular dynamics, enhance synovial movement of cartilage nutrition, decrease or inhibit pain. I'm going to say that again. Decrease or inhibit pain. Assist with healing process after injury or surgery, and help maintain the patient's awareness of movement. So there's your list, and you really need to be familiar with those positive things that come about from using passive range of motion. Other uses: when a therapist is examining an inert structure, when a therapist is teaching an active exercise program, when a therapist is preparing a patient for stretching. That's a big one. Like, I'll still do passive range of motion kind of as my little warm-up before I go to stretching somebody. That's always a good thing for you to do. Look over on the next page, and you see this thing that says limitations of passive motion. Passive motion does not prevent muscle atrophy.
So mark that out.
Wait. It doesn't prevent muscle atrophy? How does it, why wouldn't it prevent muscle
Because
atrophy?
the muscle's not working.
Because there is no myosin and actin doing anything. Now, strategize for me with data-driven things. Tell me what would prevent atrophy in a patient who is immobilized. Of course, you would have to pick on the stinking electronic stuff down there. Yes, I suppose there's something out there that says that you could put some electrical current in the muscle and make it do some things.
You make them contract.
What is the strategy I gave you, though?
Crossover education.
Yeah, crossover education. Using that opposite side. Remember, that muscle is not moving, and even if I can't, now passive range of motion doesn't even apply if they're immobilized, but that still works. But does passive range of motion do anything for atrophy? No. It does not. It does not affect atrophy. You will still atrophy even if you do passive range of motion. Increase strength or endurance. It does not increase strength or endurance. And it does not assist in circulation to the extent that active voluntary muscle contraction does. So is passive something you want to lay on very long? No. You want to, as soon as you can, move from passive to what? Active. Okay, so how do I know when I can move to active? Whenever a patient is able to contract the muscles actively and move a segment with or without assistance. When a patient has weak muscle and is unable to move a joint. Active range of motion can be used for aerobic conditioning programs. And then finally, when a segment of the body is immobilized for a period of time. Active range of motion is used on the regions and above and below the immobilized segment to maintain the area's normal condition as possible and to prepare for new activities, such as walking with crutches. So, there's one other factor, though, that the book doesn't list, and that is when doctor and PT say it's okay to start active, that's when you gotta go. And it's usually pretty important for you to be familiar with what the parameters are of that patient when they can start active. But let me tell you, the day they can go on active, you want to do it. Now you can still bring in passive, like the book said, come back in there. Do some passive range, warm them up with passive, but make them do active stuff. Because of those three limitations of passive: atrophy, strength and endurance, and circulation. Those are three big things that tell you, I need to be doing active as soon as possible.
When you're warming them up, would you do active assisted?
You could. But I would strongly recommend as fast as you, now sometimes you have to use active assisted as a bridge to active and from passive to active. And so a lot of times we're gonna use that too. But still, you are doing more for atrophy, strength and endurance, and circulation with active assisted than you are with passive. And so it's not just encouraged, it's something that we should really lay our focus on. Get them to active. What's the number one goal a patient should have?
Change.
That's it.
Return
But you're working.
And get back to where they were before. all that.
Independence. Independence. And so, what's independent? Active or passive? Active. Alrighty, so on, on Wednesday, we'll kind of conclude just a few things with passive range, and then we will, we'll go into stretching. Now, on Wednesday morning,
If it's not raining.
gosh, if it's raining, I guess we just have to go to the track, go to the gym. We'll look at the weather as it gets closer.
Do I get to do the mile and one?
No, you don't bring your wheelchair to the track.
I'll tell you now, you don't want us to kind of.
Are we doing 8:30 or 9?
You tell her at 8:30.
9's gonna prohibit you from being able to get back here and clean up. You're just gonna have to stew and film. I'm used to that, so I'm around people like that all the time. I swam with Becky Adams. You guys know Becky Adams? Swam with her on Monday and we were talking. It's funny, the conversations that you have with people. We were talking about urinating in a wetsuit.
Happens every time.
Unique feeling. But she was talking about pediatrics and how you have the 4 or 5 P's. Pee, puke, phlegm. Gosh,
Did you see that when they interviewed Phelps that time? He said he pees in the pool almost every time.
I don't know how you could.
Right.
Who? It's projectile something, yeah.
Projectile vomiting?
No, projectile something. She'll tell you when she does peds. She'll give you that. She's great. She's a great therapist. And man, you want to talk about somebody you're going to learn from?
Who?
Becky, when she comes to do peds, man, it's a great, great class. I'll come sit in just because she's a good teacher for peds. Fantastic.
So 8:30 at the track?
8:30 at the track.
Colorado High School.
Yeah, you need to dress appropriately.
No high heels.
Yeah.
Yours, bro?
I got a bro. The flipper floppers and the toms and stuff won't get you very far. And I don't prepare blisters on people who are inappropriately prepared. Blake's bringing donuts.
Get on the track.
Get them before Felicia.
It's cold in here. It's so freaking cold.
Where in the world did you get that? Paul?
I was first here.
You can always opt for next week.
I really would.
Yeah, I should, 'cause this thing sucks.
Yeah, trade them. Take that one over there.
This thing sucks.
$1.
Room is not very wheelchair friendly.
I'm so proud of myself for remembering.
Hey, get out of my way, bro.
That's insane.
Hey, that baby just gets more prettier every day.
Next time I'm gonna like unload my crap.
She looks happy too. That's perfect.
I don't know.
That's what the hell these kids do. So kids start making a molar in the back. You realize that's what it was? She starts crying and whining. She got paid for her infections and come to find out I'm molar.
Stop wearing out.
Just give my kids frozen waffles.
When I went this way,
Gonna chew on 'em.
that's his point. So when I heard out of my car to drive, I'm like, scoot my whole body around.
Gotta have it on.
But with kidneys,
Is it black?
you really can't, no, it's, yes, you could.
Let me.
Yes, you could do it. Does he say right over the kidney? What you could do,
I'm like,
nice. Yeah, where do you go?
usually go to Retail Mall, like a little boutique thing they sell there.
Are you gonna go to the,
They sell it at Dillard's.
or the,
Yes, the Dillard's is never on sale. And then after it, usually like, free shipping and all that kind of thing.
I have to study
The,
because.
their Bradley Williams one.
Really?
So they have like headbands, everything there.
I didn't pay attention to that part. I guess it was just because, you know, after doing the 63, the 50 something was just, no. I need to write my name on this one.
A lot of it we should know just simply because we can't have classes too, but I wanna know.
Well, I'm so glad.
I'm so depressed.
You know what I mean?
It's all right that you can't use your legs.
I texted you about this thing.
You'll be right. You'll be right. You get healed in a week. You'll be walking in a week. Our miracle workers around here.
Maybe, that's possible. Dr. Tuck guarantees it.
I didn't either. I need to do that kind of stuff too. I tried to, but it didn't come out cute. I don't know where it came out. The stuff that I printed for this. I know, but my computer wasn't hooked to it and I didn't even realize it, I guess, and I printed and nothing came out. What is that?
Hey,
Is it a mini one? It's like a big iPhone.
I use it, do you have Wi-Fi at your house?
Yeah.
Oh, constantly. I wish I did. I'll even get my laptop out more.
Yeah.
And just get my iPad.
Can you get one of those telephone iPad that you hook up to a keyboard?
Yes.
You can? I thought you could. I mean, cause that'd be
We
like,
have attachments on
so
there
much more
tomorrow.
convenient, cause the laptop's like,
So you can copy and paste things and put them on Word or send them to your laptop together, send them to like class and stuff even.
yeah.
And they have Microsoft Word that you can download and just do all your Word stuff, yeah.
Oh, that's neat, especially since it's an Apple product, you know, like, it's weird, they have different formats and everything.
Yeah.
Hey, Miss Felicia,
What?
I done an offer to Kathy already, but I told Bill he's gonna hit you up, and they have to go over to Miss Athlete lately. He's gonna ask you to switch chairs with him.
Oh,
What
wait,
days is it supposed to rain?
yeah, cause those are bad.
Wednesday,
Wednesday and Thursday, Wednesday's
So
40%,
I need to either do
Thursday's
it,
50.
probably Tuesday then, huh?
Yeah.
Or today.
Tomorrow, I'll just grab one of them crappy chairs, and you can grab a good chair and go.
Or get a couple of too, 'cause I don't do much tomorrow on Tuesday.
Yeah, what,
Just sit around and.
I know that, I think, I don't remember what day I went. I don't remember if I went on Wednesday or Tuesday. I think I did Tuesday because she was there in the afternoon and I didn't have lab class that day.
I think she has, office hours at 11 tomorrow.
Okay.
From like 11 to 1 or something like that, cause I went as soon as
Just,
I finished
just,
the class.
just hit me up, if I happen to get this chair, just hit me up, say, hey, Paul. Okay. Small
Have a
fee,
wheelchair, back,
small fee.
Bucker wheelchair.
I'll let you ride, I'll push you over.
Something, I saw it, but I didn't
Shoot,
read that
I
one.
barely got myself
But
over
my
today.
sister-in-law said something about.
Better hit up a partner about pushing it. I hit some.
Can you do that?
Something wrong with her brain, totally.
If you do it yourself, I would suggest some kind of gloves. That's the only thing bothering me, I got like a blister right there. Or a red mark and it feels like a blister. First thing I did put over there, shut off the starter. I'm gonna give Amy some money to go get me something.
Are you?
Yeah, I just don't feel like, because I rode my motorcycle.
I saw that, I was like, see, strap it on the back?
No, I'm gonna ride my 4Runner one day this week and I can stick it in the back. If you want, we can do it together or whatever, because it'll fit in both the back of it.
Today I'll probably
Cause
load it up and
we got
get some dry fruit food.
Cause we got a rainy day or whatever, so I'm just gonna give it, when we have a rainy day, I'm gonna drive my 4Runner for sure those days. And I can just go.
I'm worried about, how am I gonna transfer this work, how am I gonna get it in the vehicle with them?
Have a partner do it, that's what I did Tuck, I pushed him out to the car and helped him get in the car, and then I just set it in the back of Amy's truck. She don't have a truck no more, or I do it today. So my 4Runner, I'm just gonna get help getting in, and then have somebody stick it in the back. But today, I'm just gonna give everybody some money, grab me a sandwich or something. Give your sidekick some money, grab you something to eat. I went, was you working Sunday? I didn't see your car, I would've stopped by and said hi, 'cause we were about Petco, me and my girls. It's like a Sunday thing, Petco. I'm wanting an Echo Rock or whatever, Echo Bacterial Rock. And I'm thinking I'm just gonna order one, 'cause I bought one there, and I mean, like $25 for a rock. You cannot believe, oh, you gotta, yeah, it keeps your water crystal clear. And they last a couple of years. But, it's like a lava rock or whatever, but it's got bacteria in it, a healthy bacteria. I tell you what it does, right now I have to, every week, every Sunday, it's a ritual, I take 5 gallons out of each one of our big tanks. And then I add 5 gallons of fresh water, because if you don't, the pH get too high from putting stuff in there.
How many fish do you have?
One, but they're big, they're outgrowing the tank. I got a 30-gallon tank. I got 3 of them. One is my daughter's, and then hers tank when I was over. But I got an Oscar, and an Oscar, most fish, they'll only grow as big as the tank will allow them, but an Oscar ain't that way, they'll outgrow the tank. I need a 70, at least well, they say 75 for each one. 55 minimum. So, I don't know. Tried to tell them all like that, but you got 2 of them, I said they don't work that way, 'cause they don't wanna be together.
Did they kill it?
They would, they'd fight to, well, and they'll kill anything you put in there, they'll eat them. No, it ain't, they're cool, they're awesome. Like when I clean, they'll kill anything you put in there. Like the algae eater had to grow in another tank that got big enough to defend itself. Like, you know how you suck stuff out of the tank? You can't see. That scar right there is sweet. I got one black and orange, and then I got one white. But it started out like that. 2 years later, they're bigger than my hand. But one's been a little sick, so I put medicine in there with him, because while I was gone, my wife overfed him. So I thought he had a fungus, but it was a bacteria, so I fed medicine him a week, and it didn't do no good, and had to switch medicines to antibacterial medicine. You know, it's a liquid, you put it in the water, and you take your filters out. He hates it, he'll go nuts and stuff. Well, it ends, that's what it was. It's half the size it was, and it acts like it's drying up, so I'm gonna go a week or 2 with no more medicine and put it back on there again, because we went 2 weeks of medicine with it, and the water was getting kind of colored, because you can't run your filters when you got medicine in there, it'll take all the medicine out the filters with the carbon, it'll neutralize it. So about any medicine you ever give them, you have to take the filters out. the black one is the one I like. The other one, I tolerate it.
What do you decorate with in there? Do you, like, do you
I got
buy
like
pretty
a-
much like SpongeBob stuff, whatever you?
No, like a shipwreck and,
Oh, yeah.
yeah, they gotta have an air stone. They dirty, they eat a lot, so they dirty up their water fast. So you gotta have an aerator in there. Like I had one that was acting, just sitting in the bottom, not doing well, the white one, I put an air stone in there. In a few days, it's active and goes very, wild. They're one of the few fish, they realize stuff going on outside the tank. Most fish, you walk by and they don't act like they're there. They'll follow you. My daughter will get right there in his face, they'll pack the glass. That mine, the little one, she feeds, she drops the food, because especially the black one, if he's feeling, when he's feeling right, he'll shoot halfway up the water. You know what tiger oysters are? You've seen them, just didn't know. They're part of the piranha family, but they're not piranhas. Yeah, they are. They are very territorial. Yeah, very territorial. But I had more in their tanks and I've had to take stuff out. You do? No. He has all them PowerPoints and like Susan read them all. I think the book is fine. That's what it looks like. I have one just like that. And then they have white. Where you see the black, they have white.
How much was it when you bought it? Was it?
$2. Yeah, $5, $6, $7, $8. I've had them a couple years, but they'll last, I don't know, 10, 15 years. Yeah, that's my white one. They're as big as my hand right now. They're a muscular fish and real aggressive. I love it. It's real peaceful, sitting there. I used to have more stuff in there, but as they grew,
I
took
did,
stuff
but I
out
got
so
a
they
key
have
after every class.
like right now, like I had a skull in there at the shipwreck and stuff, and had air bubbles coming out of the skull. I took that all out, and I just have stones on the back, which oxygenates water, and then shipwreck. I got a big ship in one tank. I was
Yeah,
thinking about
and it
taking
gets
it out
like
just so it could
crunchy
be a
sand
tank,
in there all the time.
because
It's bad.
he just needs more room.
So,
And you can't have
Just gets
plants
super
in there
dry.
hardly, because they'll uproot all the plants.
is it really? That's what my
Yeah.
wife said.
Yeah, he shredded the one. Had it in there and he
Cause I
shredded
love
it.
your
Just
dry,
gorgeous.
sexy.
And I got
pasta.
one, my wife thinks I'm ornery, but I thought my man gives him something
Fit
to do.
under
The
the
white
table,
one,
my legs are too big.
and you read about him, it's common. My black one don't do it though. He cleans out all the rock. It's bare plastic, and that's where he likes to sit, 'cause they actually rest at the bottom like that. And so when I suck out, all, you ever seen the deal that sucks water? It's just like a siphon hose, but it's big at the end.
What do you suck it into? A
Bucket. Yeah, and you kind of shake the rocks and shake the rocks, because it won't suck the rock out, but it'll be cloudy water from the water and the rock gravel, that collects. Yeah, you just clean in the gravel, is what you are, and it's cloudy and. No, they don't have that much suction, but it sucks the cloudy water up that you're. But when I do that, I put the gravel all back in his bare spot, and you'll hear him, where it's moving in rock. And it sounds so loud for that fish tank, it echoes,
It's all gone.
Oh, yeah. Oh, it pisses him off. He'll spend 3 days cleaning out that spot. And then he'll sit there, and then that Sunday, I'll put his rock back.
The
and then-
stuff